Hi everyone, we're back for part 2, section 11, and we're going to be talking about Cushing's syndrome. So this is a collection of symptoms and physical features that are produced by persistent, inappropriate, elevated cortisol levels. Just a brief patho on it. In patients with Cushing's, you have to have some basic knowledge of the hypothalamic pituitary adrenal axis that this system is regulated by the central nervous system, and the CHR, which is corticotropin releasing hormones, is produced by the hypothalamus and then released into the hypophyseal portal circulation. Through this process, ACTH is produced, and then that acts directly on the adrenal cortex to stimulate the production of cortisol and other adrenal hormones. Clinical presentation of Cushing's disease is usually gradual and may develop over months to years. Some common symptoms may be weight gain, back pain, headache, skin changes, and muscle weakness. Women may complain of menstrual irregularities and hirsutism, and men often may report decreased libido and impotence. Objectively, these patients may present with some generalized or central obesity. They may have a moon face appearance. There can be thinning of the skin and easy bruising. Most patients have muscle weakness, and this is more prominent proximally and in the lower extremities. And osteoporosis is common in these patients with elevated cortisol levels. Diagnostically, the Endocrine Society has released guidelines that one of 4 tests can be used during initial testing for Cushing's syndrome, and that includes urine-free cortisol, a late-night salivary cortisol, a 1 milligram overnight dexamethasone suppression test, or a longer low-dose dexamethasone suppression test. And then additional testing would include CBCs, blood sugar levels, and CMP. So management of Cushing's is to normalize the cortisol levels and to treat the underlying cause of the hypercortisolemia, and these patients are going to be managed by endocrinology. You may be involved with follow-up and management. One of the complications to be aware of is osteoporosis, the increased risk of infection. There's an increased risk of metastasis of malignant tumors, depending on the cause. These patients should be followed monthly in the first year, and then check for signs of adrenal hypofunction at that time, and then every 6 to 12 months. On page 905, there are corticosteroid replacement therapies that are used with these patients, so be sure and review those. Next, let's talk about adrenal insufficiency, and these are low levels of cortisol secretion, where the ACTH from the anterior pituitary or the adrenals are unable to produce the adrenocortical hormones. Addison's disease is also known as a primary adrenal insufficiency, and although it's relatively rare, it results from a failure of the adrenal glands to produce hormones because of the problem in the gland rather than the problem with the pituitary or the ACTH production. Patients with Addison's disease may complain of fatigue, weakness, anorexia, weight loss, nausea and vomiting, abdominal pain, low blood sugars, low blood pressure. These patients typically exhibit hyperpigmentation of the skin due to the elevated levels of ACTH. With these patients, you would want to check a morning plasma cortisol level, and these are going to be patients that you're going to refer. Patients with adrenal insufficiency require chronic glucocorticoid and mineralocorticoid supplementation and are prone to crises due to the inability to initiate an appropriate stress response. due to the lack of endogenous cortisol. In the primary care setting, the provider will meet most of the patient's ongoing healthcare needs and needs to evaluate for any complications related to chronic corticosteroid use, including cataracts, the development of osteopenia or osteoporosis. You'll be following these patients in partnership with endocrinology. Okay, we're on page 909, chapter 58, and we're going to start with diabetes. And we know that diabetes, whether you're talking about type 1 or type 2, is a syndrome of disordered carb, fat, and protein metabolism resulting in hyperglycemia that is caused by deficits in insulin secretion, insulin action, or a combination of both. The majority of patients with diabetes have either type 1 or type 2, but they have distinct etiologies. There is also impaired fasting glucose, which is a pre-diabetic state where blood sugars are between 100 and 125 before an official diagnosis is made. And then there's an impaired glucose tolerance, which is a pre-diabetic state where a 2-hour post glucose load, your glycemic level is between 140 and 199. Diabetes is the most common of endocrine disorders and affects over 30 million people annually in the U.S. So let's talk first about type 1, and this is a severe insulin deficiency resulting from beta cell destruction, which produces hyperglycemia due to altered metabolism of lipids, carbs, and proteins. This elevated blood sugar can cause damage to a variety of organs, including eyes, kidneys, nerves, heart, and both small and large blood vessels. On page 910, be sure and look at the iceberg of diabetes mellitus, and this can be for both type 1 and type 2, but it's a multifaceted approach, as we've seen with all of this book's iceberg diagrams. It has a physiological, a pharmacological, a support, self-care, patient education, caring, and nutrition, and how all those components come together to provide overall well-being for the patient. I'm not going to go into it, but be sure and review the pathophysiology of diabetes. Clinically, we know that these patients may seek treatment for a variety of symptoms related to hyperglycemia. We talked about the 3 P's previously, the polyuria, polydipsia, and polyphagia. These patients can also have increased need to void at nighttime. They can have visual changes and fatigue, weakness, and anorexia. Because of the hyperglycemia, the humoral immunity and leukocyte function can be decreased, and patients with diabetes may present with repeated or complicated infections. They can have decreased wound healing, and infections that are uncommon in the general population may be seen. In your physical exam, it's important to be sure and include a fundoscopic exam, as there are long-term effects of diabetes that can impact the eyes. Patients with poorly controlled diabetes can present with skin complications, so it's important to do a good skin assessment and then do a good comprehensive foot evaluation. On initial testing, the guidelines recommend a hemoglobin A1C. If someone has symptoms of diabetes, the 3 P's or weight loss, to do a random plasma glucose, fasting glucose levels, and their what the values need to be, and 2-hour postprandial levels. Those particular lab numbers are on page 913, so I encourage you to read those. Treatment of these patients requires exogenous insulin, frequent self-monitoring blood glucose levels, nutritional support, exercise, and continuing education on prevention and treatment of complications, and periodic assessment of treatment goals. On page 914, table 58.1, there are outpatient assessment and management goals of the patient with type 1 diabetes. Be sure and review those. What should be done as an assessment, every visit, lab monitoring, and then general health maintenance. So, with type 1, initial goal of treatment is normalization of the blood sugar, and this is best accomplished with insulin regimens to maintain plasma glucose levels between 80 and 130. The new onset type 1 diabetes patients often are in a crisis and require hospitalization, and they should be closely monitored with an endocrinologist and a comprehensive health team. We won't go into the specifics, but on page table 58.2, be sure and review diabetic ketoacidosis, an overview of it as a life-threatening um, glucose metabolism decompensation time, and then how these patients may present and what your clinical management of them will be. In drugs commonly prescribed 58.1 on page 916, you're going to see the different types of insulins that are available to use, and more information on when they're appropriate to use. So be sure and review those. um, it's important with any diabetic, but with especially type 1, that they're doing blood glucose levels, and the frequency and the timing of these is going to be dependent on the needs and the goals of the individual. Optimally, a type 1 is going to assess their blood sugar 3 or 4 times a day before meals and at bedtime, but could go up to as often as 10 times a day. New Newer to the market, but that has been out for a while, is continuous glucose monitoring that assesses uh, blood sugars, and these type of devices have been found to decrease the amount of time a type 1 diabetic experiences hyperglycemia or hypoglycemic episodes. There are different types of monitors available, so one should be selected based on the best needs and the resources of the patient. With type 1 diabetes, it's important to help them understand the management of hypoglycemia and when it could occur. The reasons that it can occur is excessive exogenous insulin, missed meals, or inadequate food intake. Um, Too much exercise, alcohol ingestion, drug interactions, or decrease in liver or kidney functions. Signs and symptoms of hypoglycemia could include diaphoresis, tachycardia, hunger, shakiness, and altermentation. These symptoms, though, are very individualized per the patient and could vary from mild to severe. With hypoglycemia, the goal is to normalize the blood sugar, and that's going to be completed by the patient taking in a glucose or a carb containing food, something that's a high glycemic index for rapid absorption. These foods can include a half a cup of a fruit juice with no added sugar, 6 ounces of regular soda, not sugarless or diet, a cup of milk, glucose tablets. Candy can be used. You check blood sugars about 15 minutes after treatment, and additional carbs should be given if the blood sugar remains below 70. Other components of management is going to include diabetes, and these patients should be seen by a diabetic educator. Exercise is important, but it's necessary to know when to check blood sugars and when to adjust insulins based on that. These patients are also going to need ketone testing. So there's many facets that make up the care of these patients. Frequency of follow-up visits will depend on the degree that the blood sugar is being controlled, changes in insulin therapy, and if there's complications or other medical conditions. As primary care, other conditions that can be associated with the alteration in blood sugars includes retinopathy, increased lipids, nephropathy for the kidneys, hypertension, macrovascular disease, and neuropathies. Those are all found in the follow-up and referral section in page 919. We're not going to go over those specifically, but I want you to be sure and review those. And then there's a whole other layer of care if you have someone that is pregnant. So you'll be combining your care with possibly another provider, OB, as well when you get to that, and that type of patient management. Next, we're going to talk about type 2 diabetes, and these are characterized by insufficient circulating endogenous insulin, resistance to insulin, and inadequate compensatory insulin secretion response. The book mentions several risk factors associated with type 2 diabetes. Those are found on page 923. Family history, elevated BMI greater than 45, impaired fasting glucose, history of gestational diabetes, hypertension, elevated lipids, women with PCOS, and then certain ethnicities to include African American, Latino, Native American, Asian American, and Pacific Islander. Early detection is most key with these patients, and starting prompt treatment will reduce complications of type 2 diabetes. So, screenings should be routine medical care when appropriate, based on the risk factors that we talked about previously. There are 4 lab tests that can be used to confirm diabetes: a hemoglobin A1C greater than 6.5, a random blood glucose of 200, in the presence of hyperglycemia, a fasting blood sugar greater than 126 or higher on 2 occasions, and fasting is defined as no caloric intake for at least 8 hours. And then the 4th is a 2-hour postprandial plasma glucose of greater than 200 or higher on a oral glucose tolerance test. Management of these patients with type 2 diabetes is ongoing, and it's important to provide education to prevent acute and chronic complications. Your interventions are going to be about risk reduction and managing blood sugars. Lifestyle management is a very important part of treatment and is going to consist of nutrition, activity, decreasing prolonged sitting, and in older adults, training for balance and flexibility. Lifestyle management should also include focus on mental health, sleep, and smoking cessation. Be sure and review the lifestyle management components that are on page 926 and 927. We're not going to go into that, nor are we going to go into monitoring blood glucose levels. I think we covered that fairly well in the hypoglycemia. On page 927, be sure and review the pharmacological therapy section. Medications are required when lifestyle management does not result in adequate blood sugar control. Drugs should be considered as an adjunctive therapy to lifestyle management. However, for particular patients with significant disease, the AACE, the American Association of Clinical Endocrinologists, and the American College of Endocrinology agree with the American Diabetic Association standards that pharmacotherapy can be initiated at the time of diagnosis simultaneously with lifestyle management. So there are many factors that go into determining what agent you want to use to help manage blood sugars, and you have to evaluate the risk and benefits according to the patient's age, their comorbidities, and their hypoglycemic risk. Unfortunately, each organizing body has not come together on what is the best recommendation, and there are different recommendations, but the most important thing is to find the guideline that you like, whether it's the AACE or the American College of Endocrinologists, and follow one particular guideline to help manage type 2 diabetes. Metformin is often thought as the first line medication that's recommended by several of the governing bodies, and it should be used only in patients with adequate renal function and should not be used with anyone that has a creatinine clearance less than 45. On page 929, there are drugs commonly prescribed that are non-insulin agents for type 2 diabetes, all the different classes. So I encourage you to look at those and look at the indications and then the adverse reactions and prescribing considerations. In practice, I encourage you to talk with your preceptor about what medications they choose, what algorithm they use to manage type 2 diabetes, and why they have made those decisions. And then you can begin to figure out what your go to is with someone that's first diagnosed or how you're going to proceed. Follow-up of these patients is going to be based on what their blood sugar levels are and how well controlled they are, if you're having to make changes in medications, and then if there are other complications associated with the disease. As we mentioned with hypoglycemia, there are some comorbidities that you need to follow for, and if these are noted, then they need to be managed. Retinopathy, hyperlipidemia, diabetic kidney disease, hypertension, macrovascular disease, neuropathy, and if you have a patient with pregnancy. Next, we're going to talk about hypoglycemia, which is low blood sugar levels that can be from infants through the elderly, and it is typically characterized with adults for a blood sugar that's less than 55. The book classifies hypoglycemia into 3 different types, and those are found on page 934, table 58.6, and it's broken down into fasting hypoglycemia, reactive hypoglycemia, and drug-induced hypoglycemia. The book also breaks down causes. So, for example, a fasting hypoglycemia could be due to renal failure or liver disease. Reactive could be related to gastric bypass surgery or exercise or pregnancy. Drug induced could be certain medications such as propanolol or salicylates. So be sure and review those and be aware of the different medications that may impact blood sugars. Symptoms may be present when blood sugars fall below 60, but evidence shows that brain function may be impaired with blood sugars that fall below 50. Other symptoms could include sweating, being trembly, dizzy, confused, having anxiety or palpitations. Patients may have headache, fatigue, syncope, blurred vision. It's important that you learn more about their eating habits, meal times, exercise habits, alcohol intake. On exam, you may find that these patients are showing signs of tachycardia. Physical exam, you need to pay special attention to objective signs of any endocrinological disease. You want to look for an enlarged liver or any signs of chronic alcohol abuse. You also want to assess the skin for any needle marks, which may reflect insulin injection. So do a good physical exam. Initial testing is going to be a measurement of the blood sugar. You may check that with a hemoglobin A1C or a chemistry. Management of these patients is to determine what is the cause of that low blood sugar and to normalize it and treat the underlying cause, as we mentioned. Treatment for alert patients would be drinking 6 to 12 ounces of orange juice or another fruit juice without additional sugar. If in an acute care setting and the patient is unresponsive, then you are going to give a D25 or a D50. The blood sugars should be monitored closely after an IV bolus of D50 or D25 and then repeated if needed. Hypoglycemia is considered a medical emergency because of the consequences, whether that could be a seizure, a coma, or cardiovascular dysfunction, or even death. As with our elevated blood sugars, someone that has a low blood sugar, one of the cornerstones of its management is checking your blood sugar. These patients may need to monitor glucose levels during exercise and be sure and eat at regular intervals and understand the importance of AccuChecks for early detection of severe hypoglycemic symptoms. Okay, we're nearing the end. We're chapter 59. We're just going to talk briefly about obesity and gout. But we know obesity is the excessive amount of adipose tissue. Um, excuse me, on table 59.1, there is a table on how to calculate the BMI and classify obesity. Other than the obvious of having an elevated BMI, patients that have obesity may complain of fatigue, decreased energy, weakness, shortness of breath, joint pain, increased daytime sleepiness, or depression. Um, we know diagnostically that the classification of obesity is made based on a BMI of greater than 30. When someone presents and you're having concerns for an obese patient, your initial workup is going to include thyroid studies, fasting labs for blood sugar. You're going to want to assess their lipid profile, do chemistries to assess liver function. You're also going to want to know more about their electrolytes, their kidney function, vitamin D levels. You're going to want to assess a CBC, urinalysis, and also check a urinary microalbumin test. An EKG would be recommended to assess cardiac health. The clinical management of someone with obesity requires the balance of more energy out versus calories that are taken in. So we know that lifestyle is very important in this treatment, and successful treatment includes combinations of diet, exercise, and behavioral interventions, and is more a multidisciplinary approach to help with weight loss. And these patients have higher success rates. We're not going to go into the details of exercise and nutrition and physical activity and behavior modifications. You can review on page 944 pharmacological management of different medications that are available to help with obesity. We know that there's surgical interventions, and you can have conversations and explore that further with your patient and then make referrals as necessary. Our last slide is gout, which is a metabolic disease with that produces an inflammatory arthritis that is caused by purine-rich foods that trigger this inflammatory arthritis. And foods that are high in purine, which can trigger gout, include meats and seafoods, meat extracts, yeast, beer, alcoholic beverages, beans, lentils, oatmeal, spinach, mussels and scallops, anchovies, herring, sardines, trout, haddock, mackerel, and tuna. There are several risk factors for gout, and these are found on page 946. And these could be due to decreased renal clearance of uric acids. If someone had an enzyme defect, secondary risk are related to the purine-rich foods, obesity, starvation, dehydration, alcohol use, and certain medications including thiazides, nicotinic acid, salicylates, and cyclosporin. Other conditions that can predispose someone to gout includes Paget's disease, chronic hemolytic anemia, sarcomas, renal failure, hypothyroidism, hyperparathyroidism, and diabetic ketoacidosis. The patient's going to present with an acute attack with pain, tenderness, redness, swelling of the affected joint. Most often this is the big toe. However, it could be in the midfoot, the knees, the fingers, wrists, or elbows. You're going to want to do a bilateral exam of all joints and an asymmetrical presentation of joint inflammation, redness, or tenderness, or limitation or of the joint are all typical of gout. The joint may be warm or hot to touch. There may be pain on palpation, and range of motion may be limited. On initial testing, you're going to want to check a serum uric level. You may also want to check a sed rate and a CBC. The goal is to decrease the deposits of uric crystals in the joints and to terminate acute attacks, prevent future attacks, and normalize the uric acid. Um, Pharmacological treatments for gout can include management of pain, medications to decrease the uric acid, and to help with symptomatic relief of the joint. And those are going to include your NSAIDs. Traditionally, indomethacin has been used for gout, but other NSAIDs are just as effective. With indomethacin, it's 25 to 50 milligrams every 8 hours until the symptoms subside, usually in 5 to 10 days. But it's important to be aware of what your patient's risk factors are for peptic ulcer disease, as NSAIDs can definitely impact that, and be aware of renal function and of any allergies. Another medication, colchicine, is used to help stop an attack of gout if administered within the first 36 hours of symptoms. It does have some adverse reactions, including nausea, vomiting, diarrhea, abdominal pain, and cramping. And then corticosteroids can be used orally, intramuscularly, or intra-articularly to help with symptomatic pain relief of gout. With these patients, it's important to have dietary modifications to avoid purine-rich foods, have good oral intake, and moderate alcohol intake. I believe that is the end. Thank you for your time, and have a good rest of the day.